So we are members of a special interest group for the International Marcé Society, which focuses on preventive interventions. And what we decided to do for our salon series this year is to really focus on highlighting, in this first salon, different preventive interventions coming to you from all over the world. And I think a lot of us are interested in each other's work, but we're very much working in isolation on our own projects and our own work. And this is just a nice opportunity for us to learn a bit about each other's work. And I think be inspired by each other's works, maybe change some of the ways we are working right now. And I think this will be a great salon for researchers in this space as well as clinicians in this space. And the idea is really just to share our ideas and our work, and then leave some time at the end that we can begin to talk more broadly as a group in terms of the attendees here, which is why I love doing salons. We all get a chance to really connect and communicate. So I'm Elizabeth Werner. I'm a clinical psychologist. I am the developer, along with Catherine Monk, of a preventive intervention for postpartum depression called PrEP, Practical Resources for Effective Postpartum Parenting. And I'm so excited to have Tina Montreux. We were joking about my French pronunciation, which is so bad, but to hear more about her work. So Tina, if you wouldn't mind taking it away, we'd love to hear from you.
Wonderful. Thank you so much for allowing me to present some of the work that's being undertaken here in Montreal. I will say that we had the pleasure, Joe had Canada annual conference, so it was really great to hear some of the amazing work that's been going on as well, Dr. Werner, in your area. So let me just quickly get my PowerPoint. Make sure that we have this full screen. Can you all confirm that you are able to see this full screen? Excellent. Okay. So essentially, I'm an associate professor at McGill University. I am involved in a few faculties, so primarily the educational and counseling psychology. So I'm a clinical psychologist working in psychiatry, training future psychologists. But I'm also affiliated with the psychiatry and pediatrics, which provides a good overview of good spread of the activities in which I'm involved in. I'm also the PI, the principal investigator of the Montreal Antenatal Wellbeing Study, which is translated in French up there. So we have a prospective cohort study of over 1,000 women in the greater Montreal area that we're overseeing. And we're now at the 60-month child follow-up, as well as a scientist at the McGill University Health Research Institute. So today, my goal is to try to present a little bit about what we're doing here in terms of perinatal mental health, and it's just really a little overview. I'm trying to respect the brief time we had. So I know that most of us that are here present today, we are aware of this, but kind of wanted to present the rationale and the background of what motivated the work that we're involved in at this time. So essentially, I think in Quebec, Canada, as well, across the world, globally, 1 in 4 women since the pandemic physical distress has been shown a number of times in the literature as being enough to essentially cause some difficulties during the pregnancy, but also for the impact that it has on the child. So some of the work that's been going on here in Quebec and Canada has been able to show that some of actually an economic calculator that we've developed and are now working on a return of investment or on investment sort of aspect of the calculator has been able to show that in Canada specifically, untreated perinatal mental health issues account for close to $7 billion per year. And our calculator has also been able to show that essentially 70% of these costs are attributed to long-standing challenges that arise from child neurodevelopment and other forms of mental health issues in adulthood. But I think this is really considerable when we speak to our decision makers and leaders. So we go from the concept, and actually, Catherine Monk talked about this last week about like the two generation or the intergenerational concept, the idea of that any intervention or any activities that we're going to have in terms of prevention on the expectant parent. That means both primarily the maternal aspect, but also the biological father will have, and caregiver will have an effect on the child as well. So we're not just benefiting or reducing the distress of the person that is expecting, but we're also leading to improvements or at least a changing of the trajectory, developmental trajectory of the child in a positive manner. You've probably heard as well of the first 1,000 days. So essentially, which averages up to about the first 3 years of the child are very critical in terms of brain plasticity. So knowing this, a lot of the interventions that I used to do in the past, and I still do with my parenting care, my Healthy Minds, Healthy Schools. So we work in schools with children at the elementary school level. We know these are having positive effect. But what if, by actually working with the parent, in terms of field exposure, the first home being the womb, what if by working and targeting maternal mental health and paternal mental health, we were able to actually improve the outcomes of children? And that's what's really driving our work. So we're talking about these in terms of, psychoaffective relationships, environmental factor, the womb, as I just mentioned. So quickly, I'm just going to basically review. It's going to encompass rather a lot of the projects that I'll be presenting today. And I'll be brief, I promise. I have about a slide per project. So essentially, we know the maternal distress has been associated to child's cognitive, behavioral, and psychomotor development, as I've just said. We also know, and this is what I didn't mention yet, is that in Canada, for example, our guidelines just arrived very recently by a team comprised of CanMat. I had the privilege of being able to not necessarily be on the project, but be one that followed the project throughout. We know that essentially the reason why people were not screening for perinatal mental health issues during pregnancy is because they felt that they did not have the adequate training to do so. And so therefore, it's not because they didn't want to, but rather they felt unprepared. Healthcare providers felt they didn't have the adequate skills to be able to screen for those perinatal mental health issues. And so this is what I just presented now. An article by Hicks published in 2022 in Canada actually surveyed thousands of healthcare providers, and this is what they attested. I have to say, before 2025, Canada did not have specific guidelines for screening and referral in pregnancy. This is just brand new. It just dropped in the Canadian Journal of Psychiatry very recently. And so therefore, I guess Hicks and team, in order to reverse the lack of training, screening and referral, rather, we're hoping to be able to really give a appropriate depiction of what was going on in Canada. So knowing that if we intervene in pregnancy via mom and dad, we may actually benefit the child, we developed this online perinatal program to promote well-being, but also to prevent depression in new parents. I don't have that much time to talk about this, but what we ended up doing is that, you're probably very familiar with the intervention Mothers and Babies that is from Palo Alto in the US. We worked very closely with the original authors, and we basically adapted the content, not just for French, but we also added several components to the program, of which the program heavily relied on behavioral activation specific for depression. And we basically adapted it to also include a lot of aspects of cognitive restructuring, identifying cognitive distortions, which really falls into the David Burns type of approach, cognitive skewed thinking, and also third wave. Hayes's sort of like model of acceptance and commitment therapy. So I want to mention, I think someone has their microphone open and there is a bit of shuffling going on. So if someone could just basically tend to that, that'd be wonderful. So quickly, I'm just going to present essentially, you see here, we had a superiority trial, RCT, for this, given that for ethical reasons, if we assumed that there were going to be benefits, we basically wanted to offer the intervention online, completed alone, and then an intervention where there was weekly or punctual coaching sessions for the expectant people randomized to that condition. So essentially, you see the breakdown here. So we had 510 women that completed the RCT. Again, they were allocated to either of the categories. Regardless of the groups that they were allocated to, they were actually completing a form of the program. And this is, I just mentioned here, we had my collaborator, which is the lead on this, Dr. Sylvana Côté from Université de Montréal. So here quickly you see, I'm going to go quickly through the results, but you can essentially see, and these are results under review at the moment. So if you could just kind of abstain from taking any photos, you can report it if you want, but it should be published very soon. We did not, if you look at the graph here, we did not find any, and this is great because at the moment, this intervention is deployed throughout the province via our health services. So it was actually adopted by the Quebec Health Services, and it's being distributed and recommended as a self-help intervention in the sort of like digital health mandate. So what we see here is that whether you received the coaching via a coach that I happened to train. So they were basically not therapists, just people coached to really offer active support. You see that there are no differences between those that received coaching over the phone and those that completed, the women that completed the intervention online. What we did do, however, is that we paired it with another, I would say, treatment as usual cohort that is also Montreal based, led by Annick Berard, and I have the reference there with Georgie in 2023. They were not receiving, and we made sure that we controlled that these women were not receiving any form of intervention during that period. And we see here in the lower bar that the well-being, so both in here, I'm presenting the EDPS, which measures depression symptoms, but we also observe the same or very similar patterns with JD7, so basically anxiety. So we see that women that were basically over during the pregnancy period, but also we see an elevated benefit as well. So they start doing better over time up until 6 months. And that is compared to a cohort that was not receiving any services. What we also found is that when we looked at women, so we did want to still see, is there something different? Because we know from the literature that supportive therapy or coaching should offer some form of benefit. So we did see, however, though the women did not differ in terms of anxiety and depressive symptomology, they did differ in terms of measures of self-efficacy at 3 months postpartum. So a lot of these women were reporting really feeling as though they were better parents, that they were able to better deal with the adversities or the challenges that come with transitioning into parenthood. So that's something that we really enjoyed seeing. But also we do know that most of the women that are depressed or anxious tend to also perceive that their children have greater difficulties, or at least they worry more about it. And we were also able to see that at 6 months postpartum, maternal perception as measured by the ASQ, so the Ages and Stages questionnaire, was actually more positive. So a more positive appraisal of child's social emotional skills at 6 months postpartum. So that was a very interesting result that we were able to find as well. I'm going back here. So quickly here, on the question of training our future healthcare providers to better be able to screen and refer for mental health issues, we used a template that exists throughout, actually it's from New Mexico in the US, it's called ECHO. And ECHO is essentially a teletraining platform that is very protocol, but it can be adapted to any type of theme. And so what we did is we adapted this platform, and this protocol of training was essentially sort of a brief presentation, 20-minute presentation, and then a case discussion format that totalizes 90 minutes. And this cannot be shifted. It's the way that ECHO actually works. And so what we're actually doing at the moment, we've got some preliminary results, but essentially this is being held virtually. So it's 6 sessions of 90 minutes once monthly, and we're really targeting various healthcare providers across the healthcare system. We currently are on our 3rd cycle. We are approximately admitting 60 or so per cycle. So at the moment, we've had 126 healthcare providers in perinatal mental health of some sort that have been essentially taking part in this training. You can quickly see here, I'll just leave this slide to show like the process of validation of efficacy that we're completing. And you may have questions later on, but essentially what we're seeing is that we're wanting to see, for example, are we changing attitudes in healthcare providers. We know that healthcare provider negative attitude or stigmatizing views of mental health actually impairs the quality of the care. So we're wanting to see, are we improving healthcare provider attitudes, and therefore are we improving also the care that they're receiving? And so we have a mixed method approach where we're actually having questionnaires that are completed on mental health stigma, on the quality of the care being rendered, both from the part of the healthcare providers as well as the people receiving the care. And so therefore, we're also conducting interviews, and we're hoping, at least our preliminary result that were presented last week at the DOAD conference is showing in a small amount of individuals, they are reporting a change in attitude, and they are feeling as though they're better prepared for screening and referral. So quickly, last little bit, and I'll end on this. We actually have another screening and referral protocol project that we're running with midwives. Midwives, you might ask why, because midwives have actually been very open to receiving the prescribed level of care. So we know that an informed trauma care framework is probably the best to be able to implement this sort of dialogue, relationship of care, maybe even like case-based management form of care. And so therefore, at the moment, we have a protocol that is being implemented. I believe we're in the hundreds. I think our next slide will show that we have our protocol paper under review at the moment with BMC Health Services. That's taking quite some time to actually review, but we hope that that's going to be available very soon. But just quickly, just some qualitative things. We're seeing that the mental health providers, in this case midwives receiving the intervention, are reporting that they feel like they need more training. They are feeling that the training that they're receiving is helping them better refer the clientele into the more appropriate level of care. And we also see that they're agreeing that this form of care pathway, collaborative care model would be the way to go in order to better service the clientele. So I will end on that. I really thank you for your attention, and I look forward to any questions that may come up during the discussion period later on.
Thank you so much. That was amazing. You got a lot in. We've been very busy, and really interesting work and a lot for us to think about. Jorge, do you want to take the floor and share your work with us?
Just can you see it? Yeah, thank you. Thank you very much. Well, thank you. I'm Jorge Osma. I'm associate professor at the University of Zaragoza in Spain, and also past president of the Spanish Marcé regional group. And together with Veronica, Laura, and Elena, we have been conducting different studies on prevention of emotional disorders in women undergoing fertility treatments. The project it calls REFER in Spanish. It's like emotional regulation in fertility treatments. Well, some brief context. We know that 15% of couples worldwide present fertility problems. Receiving fertility treatments is associated with physical, emotional, and economic burden. And from 25 to 75% of women receiving these treatments develop an emotional disorder. This is anxiety, depression, or related disorders. And we already know the high comorbidity in these disorders. And these disorders are also associated with discontinuation of fertility treatments. On the other hand, we know that we already have some psychological transdiagnostic interventions focus on transdiagnostic mechanisms shared by all emotional disorders. And one of them is the Unified Protocol. And we have developed some adaptations of the Unified Protocol for health conditions. And one of them is for women undergoing fertility treatments. So the first study we did was this pilot study. The aim was assess programs' acceptability, satisfaction, and also some clinical data. because we wanted to know if we can prevent anxiety and depression symptoms in women that they didn't have any symptoms, emotional symptoms. So we want to keep in this position during all the treatments, fertility treatments. So we developed these 6 online sessions, 2 hours duration with the Unified Protocol. And the aim of the Unified Protocol, as you know, is to increase the tolerance to unpleasant emotions by training emotional regulation skills. So we use some of the models, like the first one, adjusting expectations, also the analysis of emotional experiences, the third module about mindfulness training, and cognitive flexibility, behavioral flexibility, and the last one, it's related with pleasant activities. And we add 2 more modules, problem solving and communication skills, assertive communications, because we think this is important in this sample. And we removed, if you know the Unified Protocol, the original one, we removed those modules associated with clinical presentations like exposures or for example, relapse prevention. Okay, so the results were the Unified Protocol seemed to be useful and well accepted in the human reproduction unit, and also by women. And women were able to learn emotional regulation skills. They share with us, and she told us that they were able to use and to manage unpleasant emotions during the treatments, which well, some of the emotions were triggered for situations like not getting pregnant, miscarriages, finish all possible intrauterine inseminations. And also, this study was conducted when it started the pandemic, the COVID pandemic. So imagine if we were very stressed with the pandemic, imagine these women, the units were closed and they didn't know if they are going to open, when it's going to happen. So it was very, very stressful for them. Despite all these situations, they maintain subclinical anxiety and depressive symptoms, and also a very good quality of life. So considering this positive first data and knowing that we don't have psychologists in the human reproduction units in Spain, so preventive intervention are not provided, and I think it won't be in the future neither. So we thought that we should develop a completely self-applied program based on technology. We first did a systematic review of telemedicine solutions, and we learned that there is a lack of preventive interventions in this population. The interventions are not based on a transdiagnostic approach, so they are not targeting the comorbidities. And also we saw that there is no studies in Spain. But despite of this, it's true that there was we found some interest in developing this kind of solutions. And we also did a focus group with professionals and those women who were part of the previous study. And they recommend us to, if we are going to develop a technology-based prevention program, we should consider to add a forum. They want to share their experiences and also information about fertility treatments and health habits, because they told us that health professionals, they don't have too much time, so they needed more information. And also those platforms or technology solutions should be personalized and include the partner. This information provided by the women started having our program. So with all this information, we create this platform, Refer, and it is a very simple platform. We didn't have money for more, but this is like a Moodle version. I don't know if you know this platform. It's the one used in the majority of the universities in Spain. Is the platform to share information with the students, and the PP and the PT, well, all the information, the materials for the subjects. And well, you can see we organize the new intervention. In this case, it's not only for women without anxiety or depressive symptoms, it's also for women with clinical symptoms. So we organize the information in 10 sessions. We incorporate to the platform videos and PDF materials. The assessment is also provided online, and we included all the suggestions made by women. You can see some of the here, some images, the videos with the therapist telling the information. And well, we are recruiting right now. We have more than 50 women doing the program. Well, we have 10 sessions, as I said, and we include all the original modules adapted with examples, of course, for women undergoing these treatments. And also we incorporated those provided for them, like art procedures and health habits. We keep the problem solving and the assertive communication skills and pleasant activities, plus the original model. So we hope that we can share data from this study in future opportunities. Thank you very much for your attention, and I'll be pleased to answer your questions too.
Amazing. Thank you so much for sharing this, and we look forward to having a discussion after, and we'll turn our conversation next to Rena. And thank you everybody for finding us again. I think a little snafu in Marcé headquarters had us on the wrong kind of Zoom. So Rena, if you wouldn't mind going next. Fantastic.
Do you hear me? You don't hear me? I have a problem with my headphones.
Very low.
Yeah, 1 second. Let me fix this.
Rena, we're not able to hear you.
Very faint.
So do you hear me now?
Perfect.
Very good. Okay, so I hope there won't be too much noise around here. So hi everyone, I'm Rena Bina from School of Social Work at Bar-Ilan University in Israel. I'm also the co-chair of this prevention SIG. And what I'm going to present today is an online perinatal depression, we call it Screening Prevention Initiative. It's called Going Through It Together. And actually, we started working on it during COVID-19. And we developed it a bit more over the past years. The people who are together with me in this whole project are the Bria Foundation and Sheba Medical Center in Israel and all kinds of other very good and close colleagues of mine. So let me see. Are the slides moving? Very good. Okay. So the first question was, when we came to this, is like, why to do an online initiative? And we're talking about mainly a screening procedure, because from what we decided, in Israel, we have a face-to-face screening procedure that all women go through a month or 2 months postpartum, some of them also during pregnancy. And from work that we did, we saw that it could help in preventing more severe cases of perinatal depression, but we saw that not all women have this access to face-to-face screening, and not all women comply with the face-to-face screening. And soon I'll talk about also some results of the study that we did on this, is that we saw that women prefer online screening to face-to-face screening. And I think the biggest issue is that, okay, if we're them, but if they're not getting help when they have like lower symptoms, then we're not preventing anything, and then we're also not treating them. So we have to see how we could get them early on enough into treatment in order to prevent more severe cases. And the last thing was that it's easy access to an online screening initiative is very easily accessed during disaster situations. So it started from the COVID-19 pandemic, that at least the screening initiatives in Israel stopped totally during the pandemic. So we decided that we need something online. And also in Israel, we're now in a war situation. So we see that it's helpful in that case also. And also natural disasters, hurricanes and earthquakes, that people are have to move away from their homes and they don't have their care providers close to them. So these online initiatives could be very helpful. And when we sat and thought of, okay, so how are we going to do this prevention program? What are the important things to do in this program? So we also gathered a lot of stuff from the literature and also a lot of work that I did and my colleagues did, previous studies. And these are the 4 points that at least we think are the most important things when you want to do some type of prevention intervention that you should consider. So first of all, the purpose of the program. So the purpose of our program was to promote women's awareness of what perinatal depression is. There are some women that don't even know what it is. They think it's one thing and it's not the other thing. The importance of prevention, the importance of treatment, and also so we know it's important, how do we prevent and how do we treat? In terms of the target population, so we targeted the entire unit. It's like a universal prevention program. So it's all women in the perinatal period. And so what was our plan? So how did this thing actually work? So first of all, we decided that it's going to be an online program because of the issues that I said before. We said it's going to be universal because we could reach all women. We don't have to reach only women that are that have already some symptoms or that have more severe cases. We could reach all women. And what do we want to give these women in this online screening procedure? And actually, I must say that this is one of the first online screening procedures that I ever heard of, because there are in some places they do screening online, but then you have like a care provider that you go to and you discuss it with. And this is an entirely online procedure. So first of all, some information about perinatal emotional states, including what perinatal depression and anxiety is. We screen the women. Okay, so we use the Edinburgh Postnatal Depression Scale on the site. And after they answer the EPDS, then we also give them feedback. They get like an automatic feedback telling them, you have over here enough symptoms that might indicate that you have some depression or anxiety, and you should turn for help. And then I'll tell you what we do with that also. And those that screened okay, but still, if women answer the EPDS honestly, they don't get zero. I don't think any woman in pregnancy or postpartum could get really honestly zero on the EPDS. So we also discuss, various emotional states. It could be in distress, but not big distress. Then we also give some self-care tips, so how women could really help themselves, and we encourage help seeking. Now, what we did was, it was also something new. We used some videos because one of the things that I work on a lot is the issue of seeking help. So if we screen women, but they don't get their help, then we didn't really do anything. So how do we get these women from the screening to the treatment? And we use something, I think it's innovative. I don't think anybody used that before, but we did some videos. And in these videos, there was like a psychiatrist talking to women in the perinatal period and talking about the importance of seeking help. Also, the woman talks about, and also the psychiatrist, in a very non-formal environment. And soon I'll talk about the results of the study, because we did a randomized control trial with this also. And the last thing that we also have in this program is a referral system, encouraging women to seek help. And not only that, we give them clear information, and not only clear information, but we also embed the link. So if we want to professional support, so community mental health services, so there's a link. You could click on a link and get to the service to leave your name, phone number, whatever, and someone will contact you back. We give also community-based support. If that's we have programs called Mom to Mom and hotlines and things like that, and also online support services, well, whether it's, Facebook groups or podcasts or those types of things. And this is just, I took a screenshot of one of the pages on our website. So So you could see that over here, we give some information. This is like the beginning. So we're saying that pregnancy and the postpartum period bring upon significant changes, and that brings to some emotional distress. And 1 out of 7 women could have some severe emotional distress. And then we give some, some of the symptoms and say, if you're experiencing these symptoms, then you might want to seek help. And then we go on, you could see, there's what I said, it's the screening itself, and then, self-help, self-care tips, and where to turn to for help. So these are the examples of sources of help that we give. So on the professional side, so mental health clinics, therapists, and on the online things we give, like Facebook groups, various Facebook groups. I'm sure all around the world, but we give the Israeli ones, and various podcasts talking about not only postpartum or perinatal depression and anxiety, but also about emotional preparedness to pregnancy and the postpartum period. And also, as I said, various community-based sources, community-based self-help groups or support groups, hotlines, and those kinds of things. So just to finish, to sum up and to say about some key findings that we found in this study, we wanted to assess the acceptability and the utility of this program, and a couple of things that we found. First of all, a very interesting thing was we checked when women access the site. So as you could see, only 40% access it during the day, but we have 60% of women that access it midnight to morning or evening to midnight, that these are the times that clinics are closed, therapists don't work, and maybe, they finished working and they have time to go online and whatever. So I think it shows that this online screening could be, at least, if not instead, but it could be a good addition to the regular screening, because a lot of women are going into this and they at these various hours that they can't seek help during the day. Other things that we found is that we had around 862 women, 75% of participants indicated preference of online as opposed to face-to-face screening. So 75% of women are saying, okay, we prefer this online screening. It could be that, from the beginning, women who went into this website are more, into going to online things, but still I think 75% is a lot. And actually it was interesting because only 30% said that they would prefer online treatment. 70% want face-to-face treatment. So it's not that it's only because it's women, that they like these online things, that they're saying treatment, I want face-to-face, but screening, maybe I'll answer more honestly when it's online. So we should think about that. We had an acceptability questionnaire. So the mean acceptability score of the online screening compared to the face-to-face was 7.49 in a range of 1 to 10. That 1 is preference, acceptability of face-to-face, and 10 is the acceptability of an online. So it's closer to the online screening. That also shows a preference. Another interesting thing was that 35% of those who screened positive, EPDS 10 or above, sought treatment. It's higher than in previous studies that we did. Okay, previous studies showed 25% of women that sought help after they were screened and referred, and here we see an elevation to 35%. And the interesting thing was that when we compared, we had the group who was exposed to this encouraging seeking help, and the group that wasn't exposed to that encouragement seeking help video. So we saw that exposure to the help seeking encouragement video was associated with higher intentions to seek help and actual mental health treatment. So I think that these short videos that show, real life situations of women that experience, perinatal mental health, some type of emotional distress, and psychiatrists that are talking in a very professional way, in like a friendship way, and in a very nice way. I think those are things that could help seeking help and getting help, and then in this way, preventing more severe depression and anxiety. That's it.
Thank you so much. This is really interesting, a lot to think about. So our last presentation today is going to be a presented video. Our presenter is in Australia and it's 1 a.m. there. So she sent us a video because she's like all of us, she needs some sleep. So enjoy this presentation from Ellie Taylor from Australia. If there's audio, we can't hear it.
Along with my Becoming Us work. Becoming
Can you
Us
hear it
is a
now?
whole family approach to pregnancy, birth, and beyond. I'll introduce myself and then share what's happening in my world here in Sydney, Australia. I was an emotionally focused relationship counsellor working at Interrelate, a not-for-profit, for 25 years. And after I became a mother myself, it was with a special interest in the perinatal period. When I found there were observable patterns in what I was seeing with my clients and between couples, I wrote Becoming Us, which was originally published by HarperCollins in Australia in 2011. I'm honoured to have served as a perinatal relationship subject matter expert for a number of university research projects, including the University of Newcastle's SMS for Dads, Supporting Your Partner When You Have a Baby, Monash University's Emotional Experiences of Early Parenthood, and most recently I was asked to consult for the Birth and Corona project through Columbia University in New York. The biggest inspirations for my work have to be Kent Hoffman, founder of Circle of Security, and the sadly missed Sue Johnson, creator of Emotionally Focused Therapy, who contributed to my book Becoming Us. I'm also honoured to have had Karen Kleinman recommend my book alongside Gottman's and Baby Makes 3. So what does the research tell us about how new parent couples are coping? Well, we know from 2 landmark studies that 92% of couples report increased conflict in the first 12 months after baby. That's from Cowan and Cowan. We know that 67% of couples report a decline in relationship satisfaction. That's Gottman and Gottman. We also know that 1 in 6 mothers and 1 in 10 dads report symptoms of postnatal or postpartum depression. But more recent research from Monash University in Melbourne has found that postpartum or postnatal anxiety is actually a much bigger issue, with 33% of mothers and 17% of dads reporting symptoms. We also know from other research in Melbourne, from the Murdoch Children's Research Institute, that tracked mothers' postnatal depression over 4 years, found that the symptoms of depression worsened in that time and also increased risk for relationship breakdown and domestic violence. There was also a large study done in Norway, about a 50,000 cohort study, that found that the greatest source of antenatal anxiety for women was concerns about their relationship with their partner. So what if we stood back a bit and took a wider view of the research? Relationship counsellors, or LMFTs, can tell us that couples normally tend to go through a period of growing apart after they start a family, and that this can impact both parents' mental health, because psychologists can tell us that parents' mental health and relationship satisfaction are intertwined. One undermines or supports the other. And thanks to all the wonderful research that's been done in adult attachment, hormonal and neuroplastic changes in both mothers and fathers or parents, adult partners are not only biologically primed to bond with their baby, but the perinatal period is also a window of opportunity for them to become more securely bonded with each other. And so learning all this brought up 3 burning questions which continue to guide me. What if antenatal and postpartum professionals could support secure attachment between partners as they transition into parents? Could relationship interventions support both parents to bond more securely with their baby? And how might supporting what I call whole family bonding benefit parents, babies and families at different stages of their parenthood journey? So what is Becoming Us? It's an adult attachment-based developmental model of the perinatal period. It's father and partner inclusive and designed to support the mental, emotional and relational well-being of the whole family. Stage 1 and Stage 2 of the Becoming Us model prepares and supports expecting and new parents for nest building. So now I'd like to share with you our Becoming Us nest building pilot, which happened here in Sydney between 2020 and 2022. A gap in antenatal preparation and postpartum support for couple relationships was identified through community consultations. Funding allocated for professional and community capacity building and prevention early intervention service delivery was provided. 2 training and parents programs were evaluated, Gottman's Bringing Baby Home and Becoming Us, and thankfully Becoming Us was chosen, and I provided training for 22 staff from 2 hospitals and 8 local community groups. The Becoming Us nest building intervention was delivered to 16 expecting couples at the St George and Sutherland public hospitals in Sydney. So a little bit about the participants. The age range was between 18 and 44 years, with the majority between 25 and 29. 18 participants were originally born in Australia, 5 in Bangladesh, 2 in Colombia, 2 in the UK, 1 in Lebanon, 1 in Kuwait, 1 in Ireland and 1 in the Netherlands. Other participants identified as Aboriginal or Torres Strait Islander. We asked participants, how might this program help you to bond more with each other? They said, be more aware of each other's needs and communicating these better to reduce conflict. More awareness around the fact that my partner's needs are different and how I can identify what they might need when things get hard. Knowing there are different levels of intimacy is very helpful and definitely something we will use moving forward. We will be able to communicate more frequently and openly, and knowing we're a team, although our lives have changed in a huge way. We also asked them, how might this program help you to bond with your baby? Understanding my baby's signs and what he or she wants, reassuring to learn there will be plenty of time for bonding, reducing stress in the household, knowing ways to play and bond, enjoying the new chapter of life in a more positive way, and being aware of and managing conflict better will indirectly help to bond with the baby. Other takeaways were, it was helpful to know what to expect past the labour and birth when you're at home with your new family and the changes to routine, priorities and life. It gave us practical tools to help cope with the overwhelming emotions of parenthood. Really important topics like managing conflict, identifying stress signals in yourself and your partner, and discussing your hopes and dreams. And our relationship needs to continue to be built. As a result of the pilot, Becoming Us nest building sessions have been integrated into antenatal education at the St George and Sutherland hospitals in Sydney. Around 500 first-time birthing couples have been prepared and supported through this approach. I'm currently partnering with Wollongong University in Sydney to evaluate the Becoming Us training for care providers, and Wollongong University are also evaluating the Becoming Us antenatal and postnatal bridging program. We are seeking opportunities for international partnerships to prepare and support more families, especially during these difficult times. Thank you so much for your time and your important work. I'm sorry I couldn't be with you today, but I would love to connect. You can find out more about Becoming Us at becomingusfamily.com, or please email me at ellie@ellietaylor.com with any questions you might have. Thanks again for having me and have a great day. That's goodbye from me in Sydney, Australia. Hello, my name is Ellie Taylor. I'm a
Great. Thank you so much to Ellie. And we have just a few minutes left, and thanks everyone for your patience with the technology troubles. I'm so pleased to announce everybody really moved over. So thanks to everybody who found the other link and moved over. Any questions for the group? I checked in the chat and I didn't see any. Does anyone have any questions that they would like to ask our presenters? I just, it's so interesting being in this field for a long time and seeing how many people are using technology to make treatment more accessible. I feel like that's what I'm noticing across these different presentations. And it's really interesting to find out ways that we can be personalized and helpful. And actually, I think, Rena, in your work, right, get people more willing and more open to thinking about getting treatment just by making it more available to them. That was more of a comment, Rena, but if you have more to say, we'd love to hear.
I just wanted to say, no, first of all, the presentations, I love them very much. And I want to say something to Tina, because I did a lot of work also on preparedness of nurses to do a screening and intervention and referral program. So it could be really interesting, to discuss. We don't have time here, but maybe, one day to discuss the work that you're also doing and see, things that are similar or different. We have public health nurses here in Israel, and you're doing it with midwives. So, but still, it's more or less, they're like from the same field, and I think that the same thing is that they're not trained in mental health to start with.
Yeah.
You have to get them to be, yeah. So
I was just thinking along the same thing, Rena. I was thinking, how could we leverage this, the Marcé Society International, this specific group for, I guess, we're doing similar things, in order to be more collaborative as opposed to, just kind of working in silo and in parallel. So maybe, I think it's along the same lines, but I will definitely reach out.
I think that's
the goal.
We're also training nurses and nurse practitioners and doulas to do our intervention. It would be this could actually be, I don't know if a salon or just a meeting, like a think tank sort of meeting where we can talk about challenges we've been having, because I think, and also benefits to it. I mean, the ability to access a lot more women, and maybe it's not enough for everyone, but I do think giving someone an introduction to mental health care and a warm handoff, maybe to a mental health provider, it's a huge benefit. So many, these conditions are so undertreated. And Tina, like you said, you have the cost of that is huge. And that really ties in also into Jorge's work, right? About accessibility.
Absolutely. So maybe we can do, like, I don't know, like I know that last year we ended up doing something with the SIG for maternal mental health. We ended up doing a special symposium. So I know that there's the Mona coming up in November. I don't know if some of you folks are planning on being there in Toronto, but that could be something to look at, like addressing common challenges and barrier and posing, like lessons learned, like from other countries, and how we can basically help each other out, advance this area of research and clinical care. That's the thing. It's not just research, it's clinical care as well.
Yeah, I will talk. We were going to have a meeting just of our SIG in general, but maybe we could transform it into having more of a focus. That would be great. And in the chat, I put a link just to the webpage for the special interest group. And so if people are interested, please let us know. We love to hear from you, and we should be having our next meeting in a couple of months. And we love new members, and this has been really informative. And thank you all for taking the time to spend wherever you are, the morning, the afternoon, or the evening with us. We really appreciate your interest in this work and being part of this community. So thanks a lot.
Thanks,
yes,
Liz,
thank you for this opportunity.
Thank you.
Bye, everyone. Thanks, everyone, for presenting.
Thanks, guys. Bye.